Hello guys, welcome to the ACUR at the ANU presentations. We acknowledge and celebrate the first Australians on whose traditional lands we meet and pay our respects to the elders past and present. Today we have, so this is the nursing and caregiving session. We have our judges, Melissa Davis and Adiba Fatah here today. We have today 3 student presenters, Elissa, Brandon and Natalie. Our first presenter will be Elissa. So you can go ahead whenever you're ready, Elissa.
Thank you. Okay. Good afternoon, everyone, and welcome to my honours research presentation titled Nursing Students' Perception of Their Knowledge, Role and Experiences in Nutrition, Education and Care. My name is Elissa Price and I'm a University of Wollongong Bachelor of Nutrition and Dietetics students. And before we proceed, I would like to give a special thanks to my academic supervisors, Lorraine Fields and Professor Eleanor Beck, for their ongoing support throughout my honours year. So where do we link nutrition and nursing? Florence Nightingale, who is widely considered the founder of modern nursing, emphasised nutrition as the second most significant element of nursing practice. She goes on to further say that nursing extends beyond the administration of medication to include that of the administration and selection of diet. Some further background for this research is that chronic disease is Australia's largest and most rapidly increasing health burden, and nutrition exists as one of the top 5 most well-known modifiable risk factors for chronic disease. Registered nurses are uniquely placed throughout hospitals and numerous primary care settings to deliver a broad spectrum of care, including nutrition education and management. This is represented in research as over 90% of nursing respondents in an Australian study had requests for nutrition-related information from patients and their family. Regardless of this, there are no current existing nutrition education standards within the Bachelor of Nursing degree at the University of Wollongong. Therefore, Australian nurses have identified throughout research that they lack the knowledge and the confidence to deliver effective nutrition education and care to patients. This research is a continuation project from Madeline Egar's 2020 honours thesis, exploring strategies for maximising nutrition knowledge and skills for registered nurses. The key message of this research, however, is to identify nursing students' perceptions of their knowledge, role and experiences regarding nutrition care and education to guide future curriculum planning. This research was approved by the University of Wollongong Human Research Ethics Committee and the protocol number can be found on the screen. Students were conveniently sampled from those studying a 2nd and 3rd year Bachelor of Nursing degree at the University of Wollongong main campus prior to scheduled class times and through relevant Facebook groups. We had 13 total participants, 11 females and 2 males, where we completed semi-structured interviews online using Zoom. They were audio recorded and electronically transcribed verbatim using Otter AI technology. We had a list of indicative questions that were utilised to facilitate discussion. A semantic coding approach was used with an inductive thematic analysis using NVivo Qualitative Analysis software package. On the screen, you can see an overview of the thematic analysis from the data, where nursing students recognise that they play a key role in nutrition as a part of holistic nursing practice, although they did this in that broader interprofessional team environment, and that the care is facilitated by that of the dietitian. The first broad theme being holistic nursing practice included students recognising that they have a key role in the nutrition care of patients. The first sub-theme being the role of the nurse in nutrition care. Students identified that they have this role as they are quite often addressing the questions of patients and their families related to nutrition. Some additional tasks noted by students included charting diets, meal assistance, monitoring nutrition impact symptoms such as constipation, vomiting, nausea or appetite and so forth, and general healthy eating promotion. They also identified that they have a key role in nutrition referrals to other healthcare professionals, namely the dietitian. Although the students recognise that they have this role in nutrition care, they acknowledge that time management and the task-orientated nature of nursing exists as barriers to providing this care effectively and thoroughly. Students also recognise that they have a basic knowledge and understanding of nutrition from their degree, and therefore we came up with this sub-theme of the nutrition-related knowledge and skills. Many students, however, interestingly identified that the somewhat knowledge that they did have actually existed from external nursing or caregiving employment, such as working in aged care outside of their degree. Students were able to identify that nutrition education could be integrated through existing content, the prime example being in medication subjects and contraindications that may exist with nutrition, or some recognise that it warrants a subject of its own, which really emphasises the importance that nurses placed on nutrition care as a part of their role. Due to this poor knowledge, however, it resulted in a lack of confidence to deliver this care effectively, and students often required to locate their supervisors for support, or they were seeking information from outside sources such as Google searching. Participants also recognise that they have this demand for greater critical thinking related to nutrition. For example, understanding the how and the why, such as why is a patient on a high protein, high energy diet in the hospital setting. The second broad theme we identified was the interprofessional team in nutrition, where nursing students said, yes, we have a key role in the nutrition-related care of patients. However, we have this role in the team environment, and therefore it is the responsibility of all health professionals. The rationale for this was the interrelatedness of clinical conditions, where one participant was able to identify that once one thing in a patient's care begins to spiral or decompensate, nutrition being the example, it then is a spiral effect from there and can compromise many other elements of their care and often requires input from additional health professionals related to this. Participants were able to identify that speech pathology also had a role in nutrition care, for example, the swallowing and chewing of food, as well as doctors had a role in nutrition care, for example, dictating meal by mouth periods prior to or after surgery. Finally, the third broad theme we identified was the dietitian. And again, yes, students were able to identify that they have a role in the nutrition care of patients. However, they alluded to the fact that it is the primary responsibility of the dietitian, as it is their job. However, with this, students had a perception of unavailability of dietitians across the hospital setting, which resulted in them identifying that they're quite often the first port of call for nutrition information for patients because of this. Corresponding to this, students also identified that they had a lack of exposure to dietitians in their undergraduate studies. And as a result, there was not a clear boundary as to where the line exists for nutrition care to be that responsibility of the dietitian or to be that responsibility of nurses. So where can we go from here? Well, given that time management was a significant barrier to providing this care, it may be that we prioritise the primary role of nurses in nutrition as the screening and referral of critical patients. This will enable us to bridge communication across nursing and dietitians, as well as increase the impact and the reach that dietetic work can have through nursing. The registered nurse accreditation standards have also discussed the addition of a fourth year to their current 3-year Bachelor of Nursing degree. This will provide or present an opportunity to integrate that entire nutrition subject as suggested by participants, or to increase the amount spread throughout current content. It will also be important to establish nutrition education standards so that we ensure we're providing cohesive, evidence-based information to patients by increasing the nutrition-related knowledge of nurses. To promote this critical thinking that was requested by participants, it may be that we utilise problem-based experiential learning to do so. Finally, interprofessional education may be plausible, so this may provide role clarity around the nurse and the dietitian in providing nutrition care, as well as help to understand team dynamics and address those negative stereotypes and professional silos that exist. For example, the perceived unavailability of dietitians in the hospital setting. That brings me to the end of my presentation, where I wish to reiterate that this research identifies that nursing students perceive that they do have a key role in nutrition care, as they're quite often asked for information from patients and patients' families, although they lack the knowledge to deliver this care effectively and thoroughly, and therefore we can use this research to guide and inform future curriculum planning. Thank you.
Thank you, Elissa, for that great presentation. So now we are opening for 5 minutes of Q&A. Judges, do you have any questions?
I'll jump in and ask a question if I can. Thank you so much, Elissa. I really, really enjoyed that. I'm actually a clinical psychologist, so I'm not a dietitian or a nurse, but I absolutely appreciate the importance of interprofessional education. And you were talking from that, perspective of interprofessional education between nurses and dietitians. I'm interested in your degree, whether you've done some interprofessional education yourself as a trainee dietitian. Have you done education either with nurses or doctors or any other professionals that you might be expected to work with in the future?
Not directly. I'm currently completing a 4-year degree. In the first 2 years, we had things like common lectures and common tutorials with broader health science degrees, although it wasn't like collaborative learning. It was more so just those common lectures, and it didn't really cross across the health science degrees, which I think I'm also looking at. I'm doing additional research into facilitating interprofessional education. And I think that's quite common throughout the existing research at the moment as well, is that there's those more like common lectures, but there's no collaborative working to problem solve in patient care. Yeah.
Yeah, absolutely. Thank you so much for that, and thank you again for your presentation. I really enjoyed it.
That's okay, thank you.
Hi, Elissa. I joined Melissa in her feedback. It was a really good presentation. And my background is business, so that's very different from what you were presenting. And it was so well structured, and I was able to follow and understand all the content, and you were communicating it in such an easy way. And that's really good. I have a couple of questions. The first one is, how long were the interviews that you conducted with the participants? And the second one is, how do you see this work contributing outside of within the university context, where you have a strong argument for the needs of introducing nutrition courses in the nursing degree?
So the interviews, the first part, the interviews were 15 to 30 minutes in duration. And we had like 10 questions that facilitated that discussion in those interviews. Could you repeat the second part again? Sorry.
The second part is how do you see this work contributing outside of a university?
Diba, we were not able to hear you in the start, so could you?
Sorry, is it better now?
It's very, very low.
I'll just change one. Like, is this working better now? Awesome. Technology.
Yeah.
My second question is, how do you see your work contributing outside of the curriculum for nursing degree? This is a good argument now for universities or for schools that focus on nursing degrees to look at adding these courses to these degrees. So do you see it benefiting in other aspects?
Like other aspects outside of nutrition, or?
Yeah, or emphasizing maybe the communication between dietitians inside the hospital, because each department or the whole hospital will have a dietitian who is helping in crafting these menus for people who are inside. So do you think that this actually sheds light on the importance of educating nurses to track what is happening behind the closet?
Yeah, I think so. I think, like as I mentioned, in increasing their knowledge around nutrition will increase their awareness of what they're looking out for in terms of patient decline, and if it does require that dietetic input. And then I suppose from there, we can increase that to include if it will need input from other health professionals. I think it would be great to move in a way where we're working more rather than as nurses, as doctors, as psychologists separately, to that more interprofessional manner where there's input consistently from all teams, so that just raising that awareness of like the triggers for referral, I suppose. Yeah.
Awesome. Thank you so much.
Great. So from the audience, if we have any questions, you can please type it in the chat, or you could raise your hand so we could unmute you.
While they're typing, I've got a question as well. I am a nurse, so this is bang on the money for what I do. So you've mentioned the interprofessional education and that use of subject matter experts being the way moving forward. In your background research, did you come across any instances where it has been integrated successfully into an education program? Has there been any work in that area at the moment?
There's definitely small amounts of work. Like a lot of, I guess, it's a lot of research, like a lot of intervention in research rather than actually establishing it in the degree as something that's permanent, I suppose. Yeah, and there's a lot of research to say that like it improves the attitudes towards different health professionals and increased awareness of their roles and how that might differ to the knowledge that others have. So yeah, there's definitely some research there. Yeah.
Thanks.
Awesome. Great presentation, Elissa. So I think we don't have any more questions. We can move on to our next presenter. So our next presenter is Natalie.
All right, hi, so my name's Natalie Tucky. I completed my honours degree of psychological science last year with the University of Adelaide, and my thesis was looking at the experiences and concerns of caregivers and patients with chronic kidney disease using an international online forum. So firstly, what is kidney disease? Essentially, it's a progressive and debilitating chronic illness which results in irreversible loss of kidney function. So without treatment, kidney disease is fatal, and the treatment options include a kidney transplant or dialysis. Now, dialysis is known to be one of the most onerous medical treatments just due to the time and intensity of the treatment. Now, whilst it's well researched, the impact on the patient in terms of the quality of life of the symptoms of chronic kidney disease and dialysis, like many other chronic conditions, there can be significant impacts to caregivers and their close family members. So caregivers can suffer from caregiver burden, which results in an impact on their physical, psychological, emotional, and sort of functional health. And whilst caregivers themselves have been well researched, and there's lots in there about the literature, there is limited research specifically looking at carers of patients with chronic kidney disease. What research there is shows us that there's two primary factors which impact a caregiver. Firstly, the impact from a social element, so the ability to work or the impact on work, the impact on travel and leisure activities. And secondly, the physical support required for the patient once that patient starts to lose their independence. So whilst dialysis has been designed to be performed either by a hospital or by the patient independently, many carers take on that role and responsibility. So social support is a factor that contributes to improved quality of life, and online social support is when an online platform is used in order to provide that support. So that might be through an online forum, a chat group, or something like Facebook, for example. So carers of patients with kidney disease might use online social support because it's from a time perspective, it's easily accessible, you're not relying upon transport or having to leave the patient under the care of somebody else. To my knowledge, there's no prior research that looks at online social support for caregivers of patients with kidney disease. As such, there's a gap in the literature, which my thesis is looking to add to. So for my thesis, I looked at finding a forum that was suitable. So firstly, I obtained low risk ethics approval through the University of Adelaide School of Psychology Ethics Committee. It required that participants be de-identified and that I was limited to public forums only. So I wasn't able to look at a forum that needed an admin approval, for example, to join. So using Google and using a rigorous research methods, including the university librarians, I found 19 potential forums. 18 were excluded either because they weren't specific enough to kidney disease, participants relating to carers, for example, or the data wasn't public. The forum that I did choose was called Caring for Someone with Kidney Disease, which is sponsored, by DaVita Kidney Care, which is a US-based organisation which provides kidney care services across the US. So I chose this forum. One, it was really rich in data and really rich in text. It was specific to carers for someone with kidney disease. At the time of my data collection, which was in May last year, there were over 200 threads. So that includes the opening post and the corresponding responses. And they were posted back from 2006 up until 2020. So because the data was quite rich in text, I was easily able to identify who the poster was. And because my thesis was focused on caregivers, I was focusing only on the opening post of caregivers. And from those posts, I was able to identify who the patient was. So from the table on the left, you can see that 48% of posters were talking about their husband or male partner, and 34% were talking or posting about their parent. So the research method that I undertook was qualitative content analysis, which is a rigorous framework that's used to distill large amounts of text into categories. So the process involved collecting my text data, familiarising myself with the content, and then using verbatim words and short phrases, I would then start to pull together my codes, and then I would group them together based on similarities to form those categories. So in total, I had 71 subcategories. And what you're looking at here is I grouped them again into 12 categories, which is the white boxes that you can see on the slide there. And then again, I grouped them into these 3 overarching categories. So one being caregiver wellbeing impacts, the use of online social support, and caregiver knowledge. And I'll run through those 3 major categories here. So essentially, this category was really about the psychological and physiological impacts to the care of that patient of chronic kidney disease. So looking at things like burnout, for example, and fatigue, but also the daily struggles with their emotions, being scared and worried, as well as things like impact on holidays, intimacy, and their ability to work. But it also included their diet as well. Also had the impact of driving to and from appointments, as well as dialysis treatment, and included elements of end-of-life preparation for the patient. Also included in here was any positive comments relating to having perspective or hope. And I'll just read through a couple of quotes that represent this category. So all I know is that it is torture for me to see him like this, and I'm feeling like I want to die myself. I know I'm suffering from burnout for sure, as I have all the symptoms, but there are no support groups near me. I have lost all interest in life, which scares me. His life and mine are all about his illness. We both live with his illness. And as a second quote, I adore him so much. I am confused by my feelings for wanting this hell to be over with, and my sadness over the loss of him. My second category was the use of online social support. So this is really about how people were engaging the online community. There were comments about the forum community itself, elements about both positive and negative social support outside of the forum. So how much support both they and the patient were receiving from family and friends in the hospital, for example. But there were lots of comments around connecting with each other and sharing feelings of guilt and obligation, and really sort of venting and it's almost resenting the patient and the situation they're currently in. So it's almost like an opportunity to really share their sort of those raw sort of emotions. I've been watching this forum for a few days and was so grateful to read that there are others out there that have the same frustrations, fears and experiences I'm having. I wish our healthcare team had told me about support groups like this one. I've become very isolated, and even though I see a therapist, I feel like no one can understand this particular hell we are both in. The third major category was how the forum was used to seek information about chronic kidney disease itself, the treatment, as well as patient symptoms. So caregivers would share information about the patient's changing behaviour and physical changes, and sort of asking for the forum community about their experiences and what they thought. There were comments in here about the patient's adherence and lack of adherence to dietary requirements and medications, and asking for support about how they can help the patient more, as well as comments both positive and negative about their interactions with health professionals. I'm beside myself with anxiety, guilt, grief. She can turn her life around but refuses to. Does anyone have any advice on how I can help her or get her help? The hospital will release her soon and it can ultimately mean her demise. I don't want to lose her, but how do you help someone that is in denial and refuses to get help? He says he has not been offered dialysis yet, but for all I know, he has but refused it. He is close to moving in with me, and at that point, I feel it was reasonable to ask him to allow me to speak with his physician's thoughts. So I guess in conclusion, the implications of this research is that there's a gap in caregiver knowledge. So caregivers aren't receiving the support they require from their health professional team, and as such are reaching out to the forum community to ask for this kind of support, as well as coping strategies about how to deal with the situation. The insights from this research can be used to educate health professionals to engage the caregiver throughout the disease progression, and not just focusing on the patient themselves. In terms of the strengths, there's really, because they're sort of happening in people's homes, it's really that raw, unfiltered commentary that's coming directly from the caregiver. There's no research or bias about what's being shared, and there's limited research bias in terms of my thesis. In terms of limitations, I'm unable to obtain participant demographics, as well as the motivation to be using the online support. So there has been research to show that lower life satisfaction and high stress levels are a motivator for using online social support. So future research could look into that aspect in terms of why people are going on these forums in the first place. Future research would be great to obtain some in-depth qualitative interviews and potentially triangulate that information with the patient and the health professional team, and to really try and articulate and identify the needs of caregivers at the different stages of the chronic disease progression. So I'd like to acknowledge my supervisor, Professor Anna Johansson, my secondary supervisor, Emily Duncanson, as well as Associate Professor Shilpa Jayasudhasan from the Central Northern Adelaide Renal Transplantation Service Research Group, who was a big advocate and support for this thesis. And I'd lastly like to thank the participants from the forum, Caring for Someone with Kidney Disease. Thank you.
Thank you, Natalie, for that great presentation. So we'll open for Q&A. Judges, do you have any questions? In the meantime, if you have any questions from the audience, please add it to the chat or the Q&A, or you could also raise your hands and we'll ask you after the judges.
Would you like to go to first this time, Madiba?
Very good presentation, Natalie. I really enjoyed this presentation. And
Adiba, you're not audible.
Sorry?
Your voice is very low. Better.
I'll try to speak louder. Congratulations, Natalie. This was an excellent presentation. I really enjoyed it. It was well structured, and I had questions, but then you pointed some of them in the limitation at the end, and I think this is excellent what you've done, and I actually don't have any questions for you in regards to this work. If maybe I can just ask, maybe I've missed this at the beginning, but why did you choose particularly the chronic kidney disease, and whether you can see the same issues happening, whether this topic can be transferred to other aspects in health, in chronic health disease?
Yeah, so firstly, the reason why I chose this is because during my thesis, there was a connection with the Central Northern Adelaide Renal Transplantation Service Research Group. So there was an opportunity to do that, and this extends previous research that a health psychologist was doing when they were looking at the quality of life of patients, and found that the caregivers were taking on a lot of that burden and responsibility. So it kind of extended that research there in the first place. In terms of the second question about whether it can be extended to other chronic illnesses, Absolutely. So, but in terms of my major categories, the impact to wellbeing certainly can be applied to caregivers and other chronic conditions. In terms of how they use online social support, absolutely. The caregiver knowledge is probably a little bit unique just because about they were asking some questions about patient symptoms and treatments and dialysis, for example, but the same sort of themes, I guess you could certainly apply to other chronic illnesses, yes.
Thank you.
Natalie, thank you for a fantastic presentation. I really, really enjoyed it, and it was really clear and quite heart-wrenching, really, you know, hearing some of those comments, obviously, about people's experiences, really, really, really difficult. And you can absolutely see some of the potential benefits of an online forum, and you talked about what some of those might be. I wondered what you either learned about that particular forum or what you might have seen along the way, because I guess the flip side is the risks of people putting information that maybe is not so helpful or information that, you know, might not be accurate. Did you see how that was managed, or did you see any evidence of that in this particular forum?
Yeah, so this forum was very much self-managed. So even though there was, I found a couple of comments from administrators. It was more about the services that kidney that kidney organisation provides. So yes, in terms of the risks of having these online forums that aren't monitored, there's misinformation being shared about patient symptoms and not actually seeking proper health advice. So I think, you know, these kind of forums, it would be great to have some sort of administrator there and present to be able to share. But at the same time, the benefits of having it self-managed is that it's really allowing people to connect directly. This forum, there was a lot of activity from patients. So I don't know if you noticed that slide I had earlier, there was quite a lot of comments and responses from patients. So often a carer would post a question and then a patient who's suffering would then go and they would sort of comment back. So there was lots of dialogue back and forth, which I actually think was quite nice, going back and forth between the patient and the carer. I didn't know. So.
Yeah, that's a really great point. Yeah, I guess the other question I was thinking about as you were speaking was around the demographics and the accessibility of online forums. Obviously, it's not going to be for everybody, and it's not going to be suitable for everybody. I wondered if you got any sense from the posts of the cultural diversity or the demographic diversity in the participants. Could you pick that up at all?
Look, it wasn't enough to provide any sort of meaningful data on. So certainly people would talk about their age, their relationship status, whether they've got kids or not, don't have kids. I didn't get any ethnicity or religious kind of. Actually, there was religious sentiments in there about praying and so forth. So there was a little bit of that in there, but not in terms of which culture they were sort of referring to. So yes and no, but not enough to really sort of provide any meaningful stats on, for example.
Yeah, really interesting. Thanks so much for that, and thanks again for your presentation.
Thank you.
Great. Do we have any other questions for Natalie? No questions from the audience. Great. Thanks for the presentation. Let's move on to our next presenter, Brandon.
Thank you. On the share screen.
Not yet. It's loading up.
Yep.
Yep, we're good to go.
Okay, so good afternoon, everyone. My name is Brandon, and my research focuses on the professional success of men in nursing. And I'd like to start us off with a riddle. A father and son are driving down a highway and get in an accident. The father passes away at the scene, and the son is transported by ambulance to the nearest trauma centre for emergency surgery. While being prepped on the operating table, the surgeon barges into the room and says, "Stop everything. I can't operate, that's my son." Who is the surgeon? You hear a few different responses to this riddle, that he was adopted and the surgeon is his biological father, or that he was raised in a same-sex household and that the surgeon is his other dad. But the real answer is the surgeon was his mother. This riddle's designed to confront our cognitive bias around gender roles and occupations. I first heard it over 10 years ago from my career advisor, and it's stayed with me ever since. And while a lot has changed in that time, the negative aspects associated with being a member of a minority group in the workplace continue to be reported. But what happens when those biases against the minority group bring with them a presumption of advantage. And that's what we look at for men in nursing. In Australia, men represent 11.4% of nurses. Globally, that number never cracks 15%. They remain a consistent minority. And while we know that it is well documented for women in minorities as contemporary organisations, they experience a glass ceiling, as we can see here on the left. They face an invisible barrier of societal and organisational forces that block them from promoting themselves beyond a certain level in the workplace. While at the same time, over 30 years ago, Christine Williams, an American sociologist, posits that these same forces that prevent women from progressing actually thrust men in women-dominated professions up the organisational hierarchy to positions of influence and status. Our man on the left in nursing is riding the glass escalator to success. And this has been the prevailing narrative for men in nursing for the past 30 years. They are successful by means of a hidden advantage. So, to examine whether men are indeed advantaged in the nursing profession, or whether they experience disadvantages as a minority member of a women-dominated workforce, I performed an integrative review of the current literature. My aim was to identify and summarise evidence of objective achievements and subjective indicators of professional success for men in the nursing profession. Using these three concepts that I've highlighted here, I accessed 7 electronic databases in January of this year in search of empirical research related to the professional success of men in nursing. Anything related to the professional success of women nurses, of non-nursing health professionals, and of nursing students was excluded. And I identified 12 studies. 6 of them were qualitative and 6 of them were quantitative. All were published between 1987 and 2021. The countries represented by these papers included Australia, China, Taiwan, Macau, Portugal, the United Kingdom, Canada, and the United States. So there's quite a range of contexts there. And the first thing that they revealed was our evidence of professional success. The first objective achievement of professional success was career progression. Only 2 studies reported career progression as their direct measurement of professional success, yet they both found that despite the consistently low representation of men in the nursing workforce, over time, they have increased their presence in senior nursing roles. It's heavy at the top for men. The second objective achievement was higher salaries. On average, men nurses are paid more. They receive these higher rates of pay due to those senior positions, as well as their presence in higher paying nursing specialties, and as well as working more full-time hours. Job satisfaction was a subjective indicator of professional success. For the men nurses who were surveyed, attractive employment opportunities increased their job satisfaction. And not only were these opportunities attractive, they were also abundant, because men in nursing are provided more opportunities for career development than their women counterparts. More job opportunities means that men are more professionally empowered and are then driven to actively pursue further career development opportunities. It's a positive feedback loop. And the final subjective indicator was support networks. Organisational support is proven to increase professional success and drive positive self-esteem. Men nurses are reported to have broad social networks that extend well beyond the nursing discipline and can also include members of the health care team, including doctors and allied health staff. And this mountain of success paints a very enticing picture for men in nursing. But unfortunately, it's just the tip of the iceberg. My review also identified a series of obstacles to professional success that were lurking just below the surface. The first obstacle was the negative imagery about men in nursing. Men nurses are assumed to be effeminate or gay, and due to the pervasive negative stereotypes of homosexual men in broader society, this resulted in negative experiences for men in nursing, like receiving homophobic abuse from patients. To combat this negative perception, the heterosexual men nurses felt it was necessary to openly declare or make some overt displays of their sexuality, like wearing a wedding band and discussing their female partner that's a woman, just to remind them during conversations. Race was another source of negative stereotyping by both patients and colleagues. White men walk into a room and are often mistaken to be doctors or supervisors. Black men that walk into the same room are assumed to be janitorial or service workers. These Black men are not afforded those same career development opportunities I mentioned before, and are also overlooked by their supervisors when it comes time for promotion. The second obstacle to professional success is the feminisation of nursing care. Nurses are gentle, they're caring, nurturing, and empathetic, and all of these qualities are assumed to be absent from men. But on the contrary, in a study of emotional regulation, men nurses were found to be equally as responsive to the behavioural cues of patients and were able to modify their own behaviours appropriately. Men are proud to identify as nurses. They maintain that the provision of nursing care is gender neutral, and they've also reported that the sense of satisfaction they derive from providing that care is the reason they became a nurse in the first place. The third obstacle to professional success was the refusal of care. Again, arising from the public's expectations that a nurse should be a woman, it was common for men nurses to experience a refusal of care from women patients and their family members. Men nurses also reported an apprehension about providing personal or intimate care, particularly when it was younger men providing intimate care to women of a similar age group. There's a fear that patients will perceive men's touch as a boundary transgression that is sexual in nature, so it's best to avoid the care altogether. And the final, fourth obstacle, was the disproportionate allocation of masculine tasks. Men are the muscles, and with that comes the regular assignment of tasks that require heavy lifting, manual handling, security duties, and dealing with the difficult patients. Not surprisingly, this means that men are represented in violence and aggression statistics more frequently than their women counterparts. So how does this all come together? As a result of this constant and negative stereotyping, men were reported to experience being pushed away from direct clinical care to non-clinical roles both within and outside the nursing profession. They also reported being pressured by a combination of personal, societal, and cultural factors to pursue prestigious specialties or higher status nursing positions. Men who chose to remain in clinical practice might pursue advanced knowledge and skills, while others made the conscious decision to go after the managerial roles that gave them an economic and professional status. Regardless of the direction they moved, the common theme was that they reduced the amount of time spent providing direct patient care. And when we look at this totality of men's experiences, we can begin to see that their visibility as a minority group is a double-edged sword. Yes, men are more successful, as indicated by their higher representation in nursing specialties, senior management positions, and professional development opportunities. But they also experience unique obstacles not generally encountered by their women counterparts. And where does that lead us from here? Not too far afield. Culture is shaped by the worst tolerated behaviours, and our continued complacency will only perpetuate these stereotypes and this false dichotomy of men versus women nurses. We're one in the same. Nurse leaders must work to address gender stereotyping and transgressions directed at both men and women. They should raise awareness of biases that threaten gender equality and prioritise education and training programs that confront this invisible privilege. They need to be advocates of diversity and inclusion, as a rich tapestry of nurses not only benefits healthcare organisations and the nursing profession, but most importantly, it continues to benefit the patients and the communities for which they continue to care. Thank you.
Thanks for that great presentation, Brandon. Enlightening a lot of us about all these things. So let's open for Q&A. Judges, do you have any questions?
I'll jump in. Thanks so much, Brandon. That was a really, really excellent presentation. It was your PowerPoints were great. Your verbal presentation was fantastic. It was really compelling. So congratulations and well done on that. You've kind of raised some a bit of a call to action there in terms of what needs to be done. In the profession, in the workplace. I guess as you were speaking, I was thinking about earlier than that. I'm thinking about what about young boys and girls who are thinking about, going into, you've got your primary school or you're even earlier than primary school age children. Are boys thinking, are you a nurse if you're a boy, or is that only something girls can do? You know, then you've got your high school students where they're actually thinking about careers. So I'm thinking about earlier than the profession. Have you got thoughts about what we need to be doing with our children and adolescents?
We do. So this is part of a few arms of the different projects. So my part focuses on profiling success of currently practicing men nurses. We're also looking at nursing students and ideally underline those that have left the profession. And what's come out as we've been reading is that there is no conversation around men being nurses at all. A lot of men come into it later in life. So for me, I've got 3 degrees, had 3 other jobs, and then I became a nurse. It took someone saying to me, hey, you should be a nurse, before I went and did it. So it's something as simple as you should be a nurse, taken back at primary school and high school age. So that career advisor that confronted gender norms never told me about anything. So there's a lot of gaps there and that expectation that we need to compete with. But it also comes up against that social force, gender and gender identity and presentation and masculinity. We've got to unpack all of that before we go anywhere near where we need to be. So that's a lot of what I'll be looking at moving forward, is how those minute aspects all come into play. But definitely there's a lot of work to be done. It's just a lot of planning at the moment, unfortunately, and recognising where it should be targeted first and where we can make the most change.
Thanks for that. And it's really interesting that you say that in perhaps, and it's your own experience, who go into nursing and not perhaps doing it straight from school or as their first profession. It may be something that they move into a little bit later on. So yeah, that's really, really interesting.
Yeah. And the ones that do come in later stay around longer. So that graduate younger leave at 4 times the rate of women nurses, but once you're in, you stay.
Because you found the right place for you and you're there for the right reasons, perhaps. Yeah, really interesting, really fascinating research. Thanks again.
Thanks.
Hi, Brendan. Congratulations. This was an interesting presentation. I very much enjoyed it. And I really loved how the script and the slides just created this beautiful story and very interesting topic that we all need to pay attention to. So I do have one question about, you have in one of your slides where you're talking about the tip of the iceberg and you're talking about career development, and you refer to the differences between female nurses and male nurses. But again, when you were talking about the case studies the cases that you have used, you excluded the cases that focused on female nurses. So was there a comparison in the case that you've taken into consideration, a comparison between male and female in terms of career development?
So some of them, yes. So from those articles, some of them focused exclusively on men. And some of them looked at men and women. So there was one that was a survey of rural Canadian nurses, and that was drawn from their census data, so had men and women. Our focus was primarily on the men's side of things, because each time it was compared to women, what was found was there is no difference. When it comes to those career progression, the presence in senior positions, qualifications, full-time career, number of hours worked, there's no difference in senior positions for men and women, but that narrative is still there. So all of those positives can be applied as equally to women as they are as men. But unfortunately, it's that early work seems to have trapped everyone in that one mindset. And we've made all of this, so 87 to 2021, that's almost 40 years, but nothing's changed. And we've got all this data that says otherwise, but that mentality hasn't been undone.
Would you say that things move fast in your field? And this is something that's not really moving as fast?
What's interesting about it? So a lot of it's driven by economies and politics and all that. We're moving constantly. I can't tell you how many memos I've gotten in the past week about the COVID changes in my hospital, but the culture of nursing is stagnant. And it needs a bit of a shake-up, but then there's arguments in the literature about at the expense of who. More men, is that less women? And no, it needs to be more of everyone.
At some point in your, and correct me if I'm wrong, the focus of the research was to look at the male nurses. But then you notice you also discussed race, and you focus on gender, and then you mentioned race. Do you think this is a topic that should be, again, taken completely separately and dig into it as something really important to look at within nursing, just with male?
Yeah, well, yes and no. It needs to be handled very carefully. So one of my favourite articles, Ada Harvey Wingfield, is an African-American woman who looked at African-American men nurses. And that's where that comes from. I call it minority compounding. The more minorities you are, the further down the hierarchy you fall. So you've got that ideal white straight man at the top, then the white gay man is one step down. If you're black, it's down again. And within that study, she actually had a black gay man who was worse off again. So it just, all of that, the intersections of gender and race and culture and religion all need to be discussed, but it can't be something that's slapdash. I don't think there's a very easy answer to it. So it needs a lot of finessing at this stage, but definitely something that needs to be discussed as well.
Thanks, Brendan. That was great work. Congratulations.
Thanks.
Brandon, we have a question for you from the audience. I was just wondering whether media representation, example, medical TV series, etc., involving male nurses might be one of the way to start these conversations and challenge these stereotypes.
Yes, 100%. There's an article that analysed the representation of men nurses in media, and it looked at shows like Private Practice and Grey's Anatomy and All Saints and how they presented men nurses. And they were the butt of the joke and sex objects and objectified by the women doctors, that their role as a nurse was secondary. Actually, I've been thinking about this recently with our new RFDS coming out. So you've got our man's man, that's the nurse, and even the new nurses show, I think it's on Channel 9. That's going to do a lot to give an idea of what nurses do. But I think the media has a lot of a role to play in more than just men. People don't understand what nurses do. And we need to unpack that a lot more as well, because the minutiae of my day-to-day is phenomenal. No one knows what I do for my 8 hours. I'm just the nurse at the bedside, but I'm keeping those people alive. I'm liaising with the dietitians and the occupational therapists and the physiotherapists and the doctors and the family members. I'm a social worker, I'm a counsellor, I'm everything. My role is phenomenal, but to understand that you have to be in it, or you have to experience it firsthand. So I think we're getting there, but mass media, yeah, we'll see how that one plays out.
Thanks, Brandon, for that great presentation. So this brings us at the end of our session. I would like to thank the judges again for taking out your time. Thanks, Melissa. Thanks, Adiba, for judging the session. And congratulations to our student presenters for the great presentations. The recording for the session will be available online after the conference, and we hope to see all of you in other conference events this week. Thank you.
Thank you.
Thank you. Bye.